I'm just curious.
Oh, yeah, I'm on first half.
Well, good afternoon. I think we can get started. We've kept you waiting long enough. Thank you for coming. So pleased that folks here have been so supportive of this little lecture series, and hope it's been helpful. Uh, the feedback we get, although folks at Butterfield are so kind and polite, they might not say otherwise. They didn't think it was so good, but has been very generous and very kind. So I appreciate that. It's a good experience for these resident physicians because the task, part of the task, in addition to honing their skills as a public speaker, part of the task is medical education or education about health in a language that's understood by folks who aren't professionals in health. You know, it's easy for us to act like we're trying to impress by using these big words, but it doesn't help a thing if you walk out not really understanding what. So their challenge is to explain the words well so that you're comfortable with them and understand what they mean. This series, we've been doing it about 4.5, 5 years now. We've gotten such good feedback on it, so even though we're repeating subjects now because we've done so many, continue to get good feedback, and any feedback you have, verbally or in writing, I'm really interested in hearing. So please don't hesitate to fill us in on any ideas you have. So most of you know this if you've been here at all. This is a series we call You and Your Health that in which our medical residents, these are physicians who have recently gotten their medical degrees in the last 1, 2, or 3 years and are doing their internal medicine residency training program here in Northwest Arkansas with UAMS, and part of their rotation is here at Butterfield Trail. This has turned out to be just a great teaching site. Thanks to you, thanks to folks who've been willing to not just come in and see the doctor, but come in to see 2 doctors. So you wind up in the clinic seeing our resident physician and seeing the attending physician too, and sometimes that takes a little longer. And often it's something that people value and appreciate too, because just that much more attention to what's going on. But at the same time, you're contributing to the medical education of these doctors, and I want to publicly, once again, thank you for doing that. That's a very generous thing. So this You and Your Health series it was a strict every month thing for a long time, and then they complicated our schedule for these doctors so much that trying to stay on some definite so many weeks apart would have one person doing it 3 times in a row and then someone else not doing it at all, and so we have to pick our times, and we try to get it roughly every month or to 6 weeks, something like that. So it's presented by these resident physicians I've been telling you about, and we try to pick topics that are that you hear about a lot, or that you know that it's out there because you've had some scrape with it or some suggestion of it, or have a friend who has, or family, that kind of thing, and to give you more information and a chance to ask questions about these. And I've been very pleased that the residents have done great research and put together good presentations. If you've been here a few times, you also recognize that I usually introduce them. And in that category of asking for your feedback, I've gotten some feedback. No one said, you do a terrible job of introducing. They were too kind for that, but they said, why don't you let them tell something about themselves? instead of you saying something you don't really know. You just so I thought we would do that. So today we have, and these are the two residents who are working with us on the current block, clinical block. We have two residents, an upperclassman, Dr. Chaudhary, and a first year, used to be called an intern. And so we have an upperclassman and a lowerclassman working together in the clinic. And I didn't say, the intern is Dr. Jennifer George. They have very interesting backgrounds, and I think I will just let them. Okay, the upperclassman is going to be the role model. Okay. So Dr. Chaudhary, just this wonderful person that she's been out here probably as much as any resident in those 5 years, a dozen times, and likes coming here, and we like having her. Here, I'll tell you one little insight into her. First month I worked with her, she let me go the whole month mispronouncing her name, never corrected me. Instead of Chaudhary, Abir Chaudhary, I was saying Chaudhary. Chaudhary. Now there's a significant difference, and if it's a difference to me, I'm sure it must cringe in her ears, but she never once complained. And finally at the end she told me, only by my probing to be sure I was, I don't know why I hadn't asked sooner. Anyway, that little.
Well, thank you. And there's lots of variations in how my name is spelled, so I've heard it all. That was the least offensive pronunciation. But as he said, my name is Abir Chaudhary. I'm currently a third-year internal medicine resident, so that means I'm in my final year of this program and will be graduating in June of 2025. I grew up in East Tennessee in a small town called Johnson City. It's kind of similar to this area, just in terms of the community feel and the mountains. I ended up in Chicago for medical school, and then came back down here. So I really enjoyed my time in this area and getting to serve you all. It's truly been an honor for me. So much so that I'm pursuing a fellowship in geriatric medicine and palliative medicine. So I'll find out in December where I end up. And with that, I will pass it on to Dr. George.
Yeah, so as Dr. Wright said, my name is Jennifer George. I am a first-year resident, which means I just started in July, but I believe I've seen a few of you around here, so it's been, I think, my third block on this clinic rotation at BTV, and I've really enjoyed it so far. I'm originally from Houston. I was born and raised there, and then moved to the Dallas-Fort Worth area to do my medical school, and so after I graduated, I decided to come up here to Northwest Arkansas. Someone told me that this area was going to be the next Austin, so I thought, you know what, I'll get here ahead of time, and then we'll see how it goes. And I think, it might be a little bit better than Austin, but we'll see how it is. But I know you guys are all here for our presentation, so I kind of want us to get going and get started on our presentation. Today's topic is going to be about thyroid diseases. So these may be diseases that y'all are familiar with. Either you or your family or friends may have these diseases. So we just kind of wanted to educate y'all about these diseases as well as just provide y'all information. And of course, at the end, we can answer any questions that y'all have. So the big question, what actually is the thyroid, right? We talk about it all the time. We say we're going to get your thyroid levels and see what's going on, but what is it, right? So it's a butterfly-shaped gland that's located in your neck. If you actually touch your neck, you might be able to feel it. It's kind of we describe it as a spongy feel in your neck. And so it plays a role by secreting hormones that can affect a variety of things in your body, your heart rate, your breathing, your metabolism. So this little gland in your neck plays a huge role in your body. And whenever something's wrong with it, we can see these multiple diseases that come out of it. But in order to understand why these diseases occur, we kind of have to understand how the thyroid works when it's at its normal state. So what I have here is an axis called the hypothalamic pituitary thyroid axis. the thyroid in itself doesn't just work on its own. It's not just there, not regulated by anything else. Our body has checks and balances within itself in order to make sure it's regulated properly. So it all begins up in the brain, in the hypothalamus. And so your hypothalamus secretes what's called TRH, or thyrotropin releasing hormone. This hormone then will stimulate your anterior pituitary. That's also kind of located in the brain as well. And so when the TRH stimulates the anterior pituitary, that will then release TSH, or thyroid stimulating hormone. The thyroid stimulating hormone then goes to stimulate this thyroid gland in your neck. That will then cause it to start secreting your thyroid hormones, or T3 and T4. What's important to note on this, though, is as this is all stimulating each other and causing you to create some thyroid hormones, it's also causing a negative feedback onto each other as well. So as you continue to make more and more hormones, at some point your body is going to say, well, this is enough. You need to stop making thyroid hormone. So the way it stops the thyroid from continuing to make hormones is at a certain level, your body recognizes that it doesn't need to produce any more thyroid hormones. So it sends a signal back to the anterior pituitary as well as back to the hypothalamus. This stops, it tells these two parts to stop secreting its respective hormones so that eventually the thyroid will stop producing more hormones. So now the thyroid's, working well, it's producing its hormones. We always talk about we're getting your TSH level, and then we might get your T4 level as well. But what is this T4, T3? So they're both thyroid hormones, but T4 is the inactive form of this thyroid hormone. In your thyroid, it produces both, but your T4 has a greater production from the thyroid than the T3. The reason for this is this T4 that's inactive gets converted into T3 in various parts of your body. So as you can see in this little diagram, so we have a T4 here getting converted to a T3, and this can happen in your bloodstream, and this is all done with deiodinase type 1. It can also happen in various parts of your cells and tissues, and this is deiodinase type 2. And then you can also have this reverse T3 where it goes back into a T3. So all these enzymes that are converting it over are similar to each other in that it helps convert it in different parts of the body that needs it. So for instance, if your body is converting the T4 hormone to T3, it's in your heart, it's going to start kind of regulating your heartbeat and your rhythm of your heart. Or if it's in the liver, it starts to convert it to T4 to T3 there in order to help the liver do its normal function. So as I kind of already mentioned before, this T4 goes out, T3 comes and gets converted into its active form in order to have this effect on your body. So it can affect the heart rate, it can affect breathing, it can affect the metabolism of your glucose, the metabolism of fat, so you can have your changes in your body weight based on this thyroid hormone, your body temperature, your menstrual cycle, brain development. It plays a huge role, which is why the thyroid is such an important gland. It has a huge impact on various aspects, and so you'll see different symptoms, different ways that this presents when your thyroid has any issues. So I wanted to talk about some of these issues as well. So one of the main categories of thyroid diseases is hypothyroidism, right? So hypothyroidism, hypo standing for less, thyroidism, thyroid, I'm sure you guys caught that part. But so when your body is not producing enough thyroid hormones, we call it hypothyroidism. So it kind of has a broad symptom presentation. You can be fatigued, you can have weight gain, constipation, joint pain, you might feel really cold. And so it's very broad. We can also relate these symptoms to other disorders not even related to the thyroid. So it's very hard to pinpoint that it's a thyroid issue solely from your symptoms. But a lot of times you'll see that when you have these symptoms, we'll start to think, let's kind of get a couple checks, let's get a couple labs, and a lot of times those labs include a TSH or the levels for your thyroid. So like I said, those labs that you'll see that we'll get is usually that TSH and that T3 or T4. So in hypothyroidism, if you kind of remember back to that axis that I was showing you before, the TSH is stimulating the thyroid, and the thyroid makes the thyroid hormones, right? So if your thyroid isn't making enough hormones, your body is thinking, hey, for some reason, I don't have thyroid hormones. So what should I do to make more thyroid hormones? I should increase the amount of TSH. So your body automatically starts to increase the amount of TSH, but the issue is your thyroid isn't working correctly. So it's not being able to produce that amount of thyroid hormone despite the high amount of TSH it's creating. So that's what we see on our end when you come in, say you're presenting with all these symptoms, and we say, well, let's get these labs just to check. When we see something like this, where there's a high TSH and your T4 comes back low, that's when we started thinking maybe there's hypothyroidism related to this. So a lot of times we'll get TSH, and if there's any abnormalities, the lab automatically, it's called a reflex, and we'll get the T4 as well. If needed, we can get a T3 if we think it's necessary, but a lot of times when the TSH is abnormal, that's when the lab automatically just checks the T4. But if not, a lot of times we need the T4 in order to see where your hormone levels are compared. Yeah. So you have hypothyroidism. We, take the lab. We just, decide to diagnose you with hypothyroidism. In terms of the treatments, would be to find a way to replace that thyroid for you, right? So levothyroxine, I'm sure many of you have heard of, or the brand name Thryroid, is a synthetic form of these thyroid hormones, particularly of T4, that we can give you. And so it's an external form, essentially, of the thyroid hormone so your body is able to take in the hormone. It then can convert it into T3, as you saw with all those enzymes from before. And then this gives us the opportunity to kind of have your body be able to do its normal function despite not having a thyroid that is able to produce that much of the thyroid hormones. So now hyperthyroidism. So we're going in the opposite direction now. We're now having an overproduction of your thyroid hormones. So how does this present? A lot of people say they start to have a rapid heart rate, or they start to feel palpitations and an irregular heartbeat. They might be eating more. They might be losing weight because their metabolism is way too high because they're having too much thyroid hormones. They're having trouble sleeping, or even their hair starts to get a little brittle, or they have skin changes and things like that. Again, very broad symptoms that we have here. There's a lot of diseases that can also mimic these symptoms that aren't even related to the thyroid. So again, it's one of these things that we look at and we consider it in our differential when we think, what could this possibly be, and get our thyroid hormone levels in order to check for all this. So one of the other things that we would do it for hypothyroidism or hyperthyroidism, is that on a physical exam, we could also check to feel your thyroid. Now we're feeling this kind of sponginess of your thyroid, but we're also seeing, is it enlarged? Is one side bigger than the other? Is it too small? So we can kind of have an idea of how this works. But it's not necessarily a definitive diagnosis. If we feel that it's enlarged, or if we feel that it's normal, you could still have a normal sized thyroid, but still present with hyperthyroidism or hypothyroidism. And so with the treatment of this, it's very dependent on the symptoms that you're presenting with. It's dependent on what's causing the hyperthyroidism itself, which I kind of wanted to go into a little bit. But again, when we start off our diagnosis of hyperthyroidism, this TSH and T4 are the first things that we start to look at. Now, hyperthyroidism, we're making too much of your thyroid hormones, too much T4, too much T3. So if we go back and remember that axis I was talking about, and we were talking about that negative feedback where your body recognizes there's too much and it tries to stop your body from creating more. So this is where the TSH would be low because your brain and your pituitary are recognizing that, oh, we have too much thyroid in the body, right? So we're going to stop secreting our hormones in hopes that the thyroid will stop secreting its hormones. But because your disease level is at the thyroid, it's continuing to make it despite the fact that the TSH is low, right? So there's a lot of kind of diseases that fall under the premise of hyperthyroidism. And I just wanted to cover two of them. I think some of the biggest causes of hyperthyroidism. And so one of them is Graves' disease. You might have heard about this. It is one of the most common causes of hyperthyroidism in the US. It's really seen, or the first onset's really seen in people ages 30 to 50, and mostly seen in females more than males, but both genders will present with this disease as well. So it will present with those symptoms of hyperthyroidism that I was talking about before. So you can present with that fast heart rate, palpitations, the temperature intolerance, brittle hair, things like that. But then one thing that's kind of specific for Graves' disease is the eyes. So like you can see in this pictures, you can see this bulging eye that comes out. Your eyelids kind of retract due to how the eyes are bulging out. You tend to get more irritated just because how big the eye is, and isn't able to completely get enough. It gets dried out a lot easier just because of how big it is. But the reason Graves' disease is kind of special in itself is because of the antibodies that it takes. So it's an autoimmune disease that an autoantibody will kind of bind to these receptors. So these are the receptors that, that TSH I was telling you about that is normal for the body to produce in order to produce more thyroid hormones. These same receptors get binded to a different type of antibody that is forcing the thyroid to make more of the hormone. So it kind of just gets stuck there, and your thyroid just keeps making it, because it thinks, oh, something's in my receptor. I think it's TSH. Let me keep making more. All right? So there's other antibodies that we look at when we see Graves' disease. So if we're kind of leaning towards, oh, we think you may have Graves' disease, we start to check labs such as anti-TPO, the TRABS, and the anti-TG, in order to make sure that these are kind of more definitive labs that tells us whether it is Graves or not. And so the other disease I wanted to mention in terms of hyperthyroidism is toxic multinodular goiters. So this is actually the second most common cause of hyperthyroidism. So the peak incidence for this most commonly caused in people with in the ages greater than 50. Again, female more often than male, but we see it in both populations. But this is really caused by chronic iodine deficiency. The reason for this, so in the thyroid, part of the process of making your thyroid hormone is that you need iodine. And so when you don't have enough, and it's a chronic issue, your thyroid may start to develop toxic multinodular goiters. So again, it's still categorized under the group of hyperthyroidism. So you'll present with symptoms of hyperthyroidism that we talked about before. What's special about this is the reason why it's called multinodular is these nodules start to form along your thyroid. And these nodules are the more active part that are starting to produce more thyroid hormone. So because you're having so many of these nodules that are considered hot, or they start producing more hormones, it's why we see that we're presented with this symptom or this presentation of hyperthyroidism, right? So again, if you did a physical exam, if these nodules are big enough, you may be able to feel these nodules, but what likely we would do is get a thyroid ultrasound or get an uptake scan in order to see whether these nodules are there and if they're actually producing more of these hormones. And I believe we have later slides that talk about the uptake scan as well and what that entails. For this disease, The treatment is beta blockers, some anti-thyroid drugs, and potentially surgery if, as well. So the beta blockers, anti-thyroid drugs, both of those are kind of to help with the symptom management overall. Beta blockers can, I'm sure a few of you at least know about some beta blockers, maybe even better than I do now. But, they kind of can bring your heart rate down. It can kind of help some of the symptoms that we see in hyperthyroidism. And then as well as with the anti-thyroid drugs, they can kind of bring your levels back to a normal level in a sense. But of course, if none of that's working or you continue to have symptoms, one of the definitive options or treatments for it is to have surgery and remove part of or if not the whole thyroid. And then of course in those cases, if we do that, you might be given some supplemental thyroid hormone, things like that, in order to make sure you have a normal thyroid levels in your body. So since I just kind of ran through a quick thing of nodules in the thyroid, I'm going to hand this off where we can talk a little bit about nodules.
Right. Oh, thank you. Do you guys feel like you have your doctorate in thyroid physiology now? For such a small gland, it's such a complex thing that controls so much in our body that we, often take for granted when it's working perfectly fine. But, when something's going awry, it can cause all sorts of issues. So kind of, piggybacking off of what Dr. George was just talking about as far as thyroid nodules. So this is going to, just be some sort of abnormal growth that's occurring on your actual thyroid gland. The incidence or, being diagnosed with this tends to occur as we get older. And it's actually 4 times more likely in females. I feel like the females are taking a big hit during this presentation. We're sorry for that. But the good news about these thyroid nodules is that 95% of them are actually benign. So they're not really something to worry too much about. That being said, though, 5% of them can be cancerous or malignant. And so, interestingly, one of the most common ways that these thyroid nodules are even discovered are incidentally. So you might, go in for like a CT scan or, an MRI of your brain or whatnot. And, because of where it's located, the scan or the image may just happen to pick up your thyroid as well. And so if it does that, the radiologist reading the imaging may comment on what's called a incidentaloma. So it's a nodule that's just found incidentally. You had no idea about it. Your doctor had no idea about it, but it was just picked up during the imaging. And so let me go to the next slide. If you do happen to have one of these nodules discovered, whether incidentally on an image or maybe you're just like feeling around on your neck one day and feel like there's something there, you do definitely want to get it evaluated, because even though there's only a 5% chance it might be cancerous, you want to make sure that it's not. And so the initial workup for one of these nodules, you're going to get some blood work, those TSH, T4 levels that Dr. George was talking about. And then the initial imaging of choice is going to be a dedicated thyroid ultrasound. And so you can kind of see this image on the right, what that kind of looks like. And so based on those results, if your TSH level comes back low, then typically the next step is going to be thyroid scintigraphy, which is a nuclear medicine scan. And I'm going to talk about that a little bit more on the next slide. And then, depending on what your ultrasound shows, there may be some features there that could be concerning for malignancy. And so in those cases, you're gonna probably proceed with what's called a fine needle aspiration, and I do have a video of that to show you guys as well. Okay, so this is the nuclear medicine scan I was talking about. And so, the purpose of the scan really is to kind of categorize that nodule as hot or cold. And so a hot nodule just means that there's increased uptake of that radioactive substance, and cold means that there's decreased uptake. And so essentially these hot nodules, the reason that there's increased uptake is that they are producing thyroid hormone, usually at elevated levels. But the good news about these is that they are usually benign. When they become problematic is when they're producing too much thyroid hormone. And so in those cases, the way to treat them might be with surgery, might be with ablation, or this radioiodine treatment. And then on the flip side, the cold nodules, the reason they're cold is because they're producing less or no thyroid hormone. And so if you do have one of the cold nodules, you're going to want to correlate that with the ultrasound findings, because more often than not, they're probably going to need a fine needle aspiration, which I think I have on the next slide. But this image here, this is what the picture of the actual nuclear medicine scan looks like. So on the left, you can kind of see that lighter area. That's what the cold nodule looks like. And on the right side, that image where that dark circle is, that's a hot nodule. Okay, so the fine needle aspiration, essentially, this is usually done by a radiologist, or sometimes some endocrinologists do this as well. But they take a really thin needle and basically insert it into where the thyroid nodule is, typically with the help of ultrasound. And they're just going to collect several tissue samples, and then that's going to be passed off to the pathologist to actually look at it under the microscope to determine, what type of cells are there. And so I put in a little video so we can actually look at what that looks like.
There are 3 simple changes I tell all of my
to numb it up. And then traveling deep to numb up the entire tract. You can see on the ultrasound, you can see the needle coming in. And now next step is taking 4 samples with similar small sized needles. And then we can track that on the ultrasound. You can see a beautiful shot of that tip of that needle going right into the nodule. That's a very good demonstration by Dr. Brady of how to get into the dead center area. And you can see it moving a little bit because of the calcifications make it a little firm. And several of these samples get sent to the pathologist, and then we always, at Austin Thyroid Surgeons, take extra sample for genetic testing if necessary. It's just the same technique several times.
Okay, so essentially, what he was doing, he had his ultrasound probe there to actually visualize the nodule, And then he had that there as he was going in with the needle so that he could see his needle actually come into the nodule on the screen of the ultrasound. So that let him know he was in the right spot. And then he just kind of went. I think they use a local sort of anesthetic. I think. No. Oh, I think so. I know it doesn't look like the most pleasant thing, but okay. And so, once the pathologist looks at those cells under the microscope, they kind of are going to put it in one of these categories. So benign obviously means that it's not cancerous, so that's always a good thing. Malignant is going to be one of the cancers. They might say that it's suspicious for malignancy, which isn't a definitive diagnosis that it's cancer, but the risk of it being cancer is higher than not. So these usually end up being surgically removed since the risk is there. If they say that it's indeterminate, these are, again, it's not a definite diagnosis, but the risk of it being cancer is actually lower. And so the way they kind of decide what to do with these is they will do some more molecular testing and genetic testing to kind of determine if this is something that they can just monitor with observation, or if they do need to, do surgery to actually remove it. And then they may also say that the sample is non-diagnostic, which is unfortunate because that means that they don't have enough tissue to actually see all the things that they need to see. And in that case, you might actually need a repeat biopsy. So hopefully nobody ends up in that category too frequently. And then in terms of the thyroid cancers, there's 4 main types, and I kind of split them up into the 2 that are well differentiated and the 2 that are poorly differentiated. If you're not familiar with that terminology of differentiated, essentially what that means, if something is well differentiated, that means those cancer cells kind of look and behave similar to the cells where they're originating from. So they tend to be, slower growing, kind of more normal. Whereas if they're poorly differentiated, they appear quite abnormal from the cells of origin. And poorly differentiated, they tend to be more aggressive and, kind of a worse prognosis typically. And so luckily the most common type of thyroid cancer is a well-differentiated one called papillary thyroid cancer. These in general have a very good prognosis. The other type you might hear is follicular, which overall also has a pretty good prognosis. And so kind of the approach to treating these, you are typically going to, have a total thyroidectomy, so they're going to remove your entire thyroid gland. And they're going to follow that with like the radioactive iodine ablation, as well as suppressing your TSH. So those, tend to do pretty well. And then as far as the 2 poorly differentiated ones, the medullary and the anaplastic. Anaplastic, I think, unfortunately has the worst prognosis, but it's also one of the least common ones. That being said, the incidence does increase as we get older, so just kind of something to be aware of. And so the treatment here is going to be a little more aggressive, just, given the nature of these cancers. So you're still going to have your thyroid removed. And then when it says neck dissection, that's referring to like the lymph nodes in your neck. And then typically also some sort of like radiation treatment as well as systemic chemotherapy. And so there's a lot that goes into diagnosing these, and it all has to do with the different types of thyroid cells that they come from, and oftentimes they don't necessarily present with any symptoms, so they're kind of incidental findings. But if you were to have symptoms, I mean, some people, again, they feel that abnormal shape or size of their thyroid. They might feel like difficulty with swallowing. They might notice changes to their voice if it's compressing on their vocal cords. So unfortunately, it's not always a cut and dry, obvious cancer diagnosis, but luckily nowadays the technology is there to really help diagnose these well. I think that's all. Yeah, that's all we had. That being said, there's so many topics that we didn't talk about because it just gets very complicated, and you guys would probably be medical school graduates by the end of that lecture. So we're happy to answer any questions you guys might have. Yes, please.
You didn't mention in any of the slides Hashimoto's disease, which is what I have.
Yeah, so unfortunate that the one slide that we didn't get in here is the one diagnosis you have. But yeah, so Hashimoto's is another category of thyroid diseases, kind of falls under the hypothyroidism category as well. So it sometimes can present in similar things that hypothyroidism symptoms that I talked about before. That tends to be how it presents, and then from there, we do our standard labs, the TSH, the T4, and continue to go down from there to find that diagnosis itself. I would love to we'll probably, next time we have this this topic, we'll definitely throw that in there.
Very treatable.
Yeah, very treatable, of course, yeah.
Most common cause of hypothyroid in the U.S.
Yes,
Is
I
that
believe
right?
so,
Yeah, autoimmune. So
Yeah.
you're in good company.
Usually leaves you with low thyroid, hypothyroid. Yeah. Well, once you get to that point, having been treated, and now you've got hypothyroidism, you've got low functioning thyroid. That's the easiest thing in the world to treat. That's just a matter of giving the hormone Synthroid or levothyroxine, and then following the lab test to get you. I say not that every case is easy, but at that state, it's just a matter of coming to ascertaining the right dose going forward based on the lab test. Do you have a question?
So what is the difference between Armour Thyroxine and Synthroid, and is one better than the other? I've been on Synthroid or L-Thyroxine since the 80s, and I tried to go on the Armour once, but it seemed to be really hard to get regulated. But I understand it's better in the long run if you do.
Dr. Wright, you can correct me if I'm wrong. I don't think there has been a trial that showed whether one's superior or the other, but
You know what they used to use for thyroid replacement? That's what we're talking about. Thyroid hormone replacement, to replace the hormone your gland isn't making. It used to be desiccated thyroid gland from animal thyroid. I think swine, seems like, yeah. And Armour was the big name in thyroid, desiccated thyroid. By the time I was finishing training, but now we're talking 40 plus years ago, it had become clear that synthetic thyroid was much more stabilized and standardized in terms of dosing and had a more predictable effect. And so Armour thyroid, the desiccated, dried gland chopped up and, taken as a pill, had fallen out of favor, and yet there's still an occasional person on it. All the endocrinologists, the experts in this, think it ought to be Synthroid or levothyroxine that you're taking. Mm-hmm. Yes. It can in individuals. Most people, thankfully, it doesn't. So. Okay. Yes.
What's the function of the parathyroid?
Ah, okay. Fair question. What is the function of the parathyroid?
We purposely didn't get into that.
So the parathyroid, by the way, is the little glands in each corner of the thyroid that serve a totally different function.
Yeah, parathyroid. I mean, I know we talk about it frequently with some patients, as far as kind of regulating, especially like your calcium levels. We talk about it in like osteoporosis. It's not something I would say like we routinely check, just as part of like regular labs, unless we kind of have a reason to. Like if you have an elevated calcium level, that's something that is of concern to us, because it could indicate, a secondary disease process that's causing your calcium to be elevated. So one of the things that we look at is actually your PTH hormone to see if that's having any effect on that.
And if you had a nodule or a swelling in the area of the thyroid, it could be thyroid or parathyroid. Then we get into imaging and blood testing and that kind of thing. Thank you. Would you go second?
I'm curious why it's so prevalent that we have thyroid issues. We have a lot of glands in our body, but everybody seems to be on a thyroid med.
That's a good question. I don't know that I really know the answer to that. I mean, we were talking about with Hashimoto's, that's an autoimmune cause, and it seems like in general, autoimmune causes of all diseases just kind of seems to be more prevalent this day and age. And I don't know if it has to do with genetics or environmental causes, combination of both. I feel like I was young at the time, but maybe like 90s, maybe even back in the 80s, I feel like Oprah made a big deal about thyroid, and then everybody started like asking to get their thyroid hormones checked, and I don't know if that had any, influence on that, but it's, people have all these really vague symptoms, like Dr. George talked about, weight loss or weight gain, fatigue, hair changes, and so looking at your thyroid is, a pretty easy, cost-effective way to rule in or rule out if that is causing some of these changes. So we might also just be looking for it more than, we were in the past.
And then,
My mother had a goiter, and that was probably in the 50s or 60s, and she was only about 40 years old.
Oh, wow.
And I kind of thought, well, maybe it's because at that time they weren't iodized, putting that in our salt.
That was a big cause at one point back in the middle of the last century.
yeah, and that's what I was about to mention too, and that kind of goes into the environmental factors about what we have. But I mean, now, at least in the U.S., we've kind of saw, like, at least it's not as much prevalent because of that. But you'll see that across the world in other countries and things like that, iodine can still be an issue, and so becoming iodine deficient can cause thyroid issues. I kind of briefly mentioned it during the presentation, but iodine's needed for your thyroid in order to make these hormones. So that's part of it. But then also, now we're seeing, just in general, a lot more autoimmune diseases as we kind of live longer, as we kind of go through, we're living life in a different way than we kind of used to in the past. So now we kind of may start to see more of this autoimmune side of thyroid that we weren't really looking into just because we never realized it. But it's still something we're continuing to research.
Could we be getting too much for the hypo? Everybody gets it whether they want it or not.
I mean, oh, she was asking, are we getting too much iodine now? So we started getting iodine in our diet and the water and everything. So are we getting that too much, causing hypothyroidism or hyper? But I mean, I don't know if there's any research that says in any way, but at least for now, we want to say we don't think so. But we'll get back to you if there's any updates on that for sure.
And I don't know if this is true or not, but somebody told me that like pink Himalayan salt is not iodinated. So if you wanted to experiment and let us know.
I'd like to follow up on the parathyroid. I've been wondering all the way through this because I have some problems with mine. There are 4 little tiny glands that are associated very closely anatomically with the thyroid gland. And I'm wondering if those nodules begin to develop, if that would interfere with the function of the parathyroid.
I imagine it probably could, depending on, maybe the actual location of the nodule and kind of the functionality, how much it's kind of affecting, since they're literally on top of one another. And so that's typically, once you get to that point, it's something that's usually under the care of an endocrinologist who is gonna be looking at those labs and trying to correlate these findings to see if that's an issue. But I think it is certainly a possibility.
The second question is, when you have a total thyroidectomy, are the parathyroids removed as well? Does that surgery remove the parathyroid glands?
Almost always.
Usually it does.
And so what do you do?
Yes, replace calcium. Yeah, you.
Monitor the calcium really closely.
Yeah, usually supplement calcium, maybe sometimes phosphorus.
Yeah. And
Thyroid, of course, yes. We'll talk about it at your next appointment.
I was just going to comment on the nutritional aspect of iodized salt. At a period of time that some of us older ones remember, people did not have iodized salt, and that has been one of the things that's brought about a change in that dietary supplements.
And this is the big, what they've been talking about, is the big health consequence of not having iodized.
And it was not international until they found out because where iodine came from did not. That's made a big difference. But you still get iodized or non-iodized salt. That's right.
Can you talk about the genetic test? Is it a genetic gene that would say who's prone or not prone, or is it run in families?
I know it's a type of molecular testing. I didn't look into the specifics of like exactly what they're looking at.
I'm not aware of genetic testing
Yeah.
for it.
But it's some type of molecular testing that they do to kind of see, I guess, whether it's high risk for being a malignancy or if it's not, in which case they can get by with just observing versus actually doing surgery. And again, that's something that's typically going to be done by an endocrinologist, or at that point possibly an oncologist or head and neck surgeon.
You mentioned that it can affect your voice, and I have an autoimmune problem. I've been to the throat doctor. She said my vocal cords looked fine. She wanted to send me to the speech therapist, and that sounded crazy to me. I said, I'm going to try it. But in the meantime, someone who lives here got help from acupuncture from a medical doctor. So I tried that for 6 weeks, and that didn't work. Now my friend's trying to get me on cannabis. But you can tell my voice is not normal. And just thyroid, low thyroid, I'm on the medication. So would my voice sound like this? What?
I think it has more to do with, like if you did have like a nodular tumor that was big enough and causing compression on your actual vocal cords, rather than like an intrinsic sort of effect on it. And that's something that, you know, you would usually, like if you felt an enlargement in your neck, or your doctor did, you know, doing an actual ultrasound to see if there is in fact, you know, something that could be compressing to cause that change. But I don't think hypothyroidism in itself would cause your voice to really change like that.
But it's like I'm hoarse all the time. It's crazy.
Yeah.
Sure.
In my 60s, I came down with an autoimmune disease. It was sarcoidosis. And before that, I was not aware of having any thyroid problem. So, of course, they gave me big doses of prednisone. And then I came down with thyroid. I didn't know if the thyroid, perhaps all that prednisone had affected my thyroid. I didn't know they were even related, thyroid and autoimmune. But
Yeah. And, you know, in general, somebody diagnosed with one autoimmune condition is at a higher risk of developing other autoimmune conditions.
I got another one.
That's the unfortunate part of that.
Yeah, I got another one.
Yeah, so
10,
I don't
15
think
years.
the prednisone itself would necessarily trigger that, unless you're in, you know, kind of in an acute illness.
It was pretty acute. I lost about 20 pounds
Oh wow.
before they figured out what it was. And I
Yeah.
was taking huge doses of prednisone.
Wow.
So whatever. I mean, now I just take a supplement.
Yeah.
And I did have another autoimmune, but they caught that more quickly, so I didn't have to take much prednisone.
That's good.
Hopefully that's it.
Any last question? Well, thank you, doctors. Well done, and thank you all for your attention and your participation, and we'll see you again soon with this. Thank you.